This video is for educational purposes only and does not replace official training, local protocols, or medical advice. Always follow your specific agency guidelines and medical control. Imagine your heart as a house, and inside that house is a plumbing system and an electrical system. Usually, the electricity tells the heart muscles when to squeeze and pump blood perfectly in time. But sometimes, the electrical system glitches out and starts firing way too fast, like an alarm clock that won't stop buzzing. This makes the heart beat dangerously fast, which means it can't pump blood effectively. That's where Diltiazem comes in. In the back of an ambulance, paramedics use this medicine like a volume knob to turn down that crazy, fast heart rate. How it works? The calcium channel blocker. Your heart muscles need something called calcium to squeeze. You can think of calcium like little keys that unlock the doors to your heart cells, telling them to contract and beat. Diltiazem is part of a family of medicines called calcium channel blockers. Here is exactly how it steps in to save the day. Blocks the doors. Diltiazem sits in front of those little doors, called channels, on the heart cells and blocks the calcium from rushing in. Slows the signals. By keeping the calcium out, it forces the heart's main electrical checkpoint, a spot called the AV node, to slow down. It's like a traffic cop telling those rapid-fire electrical signals, "Whoa, hold on, form an orderly line." Relaxes the pipes. It also relaxes the walls of the blood vessels, the plumbing. This makes the pipes wider, which lowers blood pressure and makes it much easier for the heart to push blood through the body. In short, less calcium equals weaker and slower electrical signals equals a calm, normal heart rate. Why paramedics use it? When someone calls 911 because their heart feels like it's running a marathon while they are just sitting on the couch, paramedics have to act fast. They usually give Diltiazem straight into a vein, an IV, for two specific high-speed heart rhythms. Atrial fibrillation, AFib. With our VR, the top chambers of the heart are quivering like a bowl of jello, sending hundreds of chaotic signals down to the bottom chambers, causing the whole heart to race. Atrial flutter. The top chambers are beating in a super fast, perfectly organized sawtooth pattern, driving the heart rate way too high. By giving Diltiazem, the paramedic can watch the heart monitor and see the heart rate drop from a scary 160 beats per minute down to a safe, comfortable 90 beats per minute in just a few minutes. In the ACLS protocol, Diltiazem, Cardizem, is a primary go-to medication within the tachycardia with a pulse algorithm. Specifically, it is used for stable, narrow complex tachycardias to control a rapid ventricular rate. Here is exactly how Diltiazem fits into the clinical decision-making tree and how it is dosed. 1. Clinical assessment. Is Diltiazem appropriate? Before giving Diltiazem, you must confirm the patient meets two strict criteria. The patient must be stable. If they show signs of poor perfusion, altered mental status, ischemic chest pain, acute heart failure, or hypotension, you bypass medication entirely and move immediately to synchronized cardioversion. The rhythm must be narrow complex, less than 0.12 seconds. Diltiazem is a calcium channel blocker. Giving it to a patient with a wide complex tachycardia, like ventricular tachycardia, or WPW with atrial fibrillation, can cause catastrophic cardiovascular collapse. 2. Where Diltiazem fits in the protocol. Once a stable, narrow complex tachycardia is identified, the algorithm branches based on whether the rhythm is regular or irregular. Regular narrow complex, for example supraventricular tachycardia or atrioventricular nodal reentrant tachycardia. First line, vagal maneuvers. Second line, adenosine, 6 mg rapid IV push, followed by 12 mg if needed. Third line, if adenosine fails or SVT recurs, calcium channel blockers like Diltiazem or beta blockers. Irregular narrow complex, for example atrial fibrillation with our VR or atrial flutter. First line, Diltiazem is frequently the first line choice here to slow the ventricular rate, alongside beta blockers. Adenosine is only used here if needed to differentiate the underlying rhythm. 3. Diltiazem dosing regimen. When administering Diltiazem for rate control, the ACLS protocol utilizes an initial bolus followed by a maintenance infusion if rate control is achieved. Initial IV bolus. Give over 2 minutes. Administer 0.25 mg per kilogram actual body weight intravenously. Example: for an 80 kilogram patient, the dose is 20 milligrams. Evaluate and redose if needed. Wait 15 minutes. If the ventricular rate remains uncontrolled and the patient is tolerating the medication, no hypotension, administer a second IV bolus of 0.35 milligrams per kilogram over 2 minutes. Example: for an 80 kilogram patient, the second dose is 28 milligrams. Maintenance infusion. Continuous rate control. Once rate control is established, start a continuous IV infusion at 5 to 15 milligrams per hour. Titrate the infusion rate based on the target heart rate and blood pressure. Critical contraindications and cautions. Because diltiazem is a negative inotrope, decreases heart squeeze, and a negative dromotrope, slows conduction, always screen for these absolute red flags before pushing the drug. Hypotension. Do not give if systolic BP is less than 90 millimeters of mercury. Wolff-Parkinson-White syndrome. Avoid in patients with WPW and atrial fibrillation. Blocking the AV node can force conduction down the accessory pathway, accelerating the ventricular rate into ventricular fibrillation. Severe heart failure can worsen acute decompensated heart failure, pulmonary edema. AV blocks. Contraindicated in second or third degree heart blocks unless a functioning pacemaker is in place.